Good afternoon, everyone. So I think very nice presentations are going on. We were enriched by the knowledge of C3R, now how to deal with perforations and all. So while a corneal surgeon is doing these things in his OPD and in his clinical practice, now what are the outcomes? That matters. So I'm here to just brief you out the clinical outcome of the first 100 consecutive therapeutic penetrating keratoplasties which we had done at our center. These are all brief facts which need not be mentioned and repeated because it's an important cause of blindness. NPCB estimates currently say that around 1,20,000 blind persons are residing in India, and in addition every time 25 to 30,000 patients are adding up. And the core study has defined infectious keratitis to be an important cause of corneal blindness and morbidity in Indian population. And to add on, one of the landmark studies from South India has recognized corneal ulcer as a silent epidemic of Southeast Asian region. And extrapolation of Indian estimates of the incidence of corneal ulcer approximately is 1.5 to 2 million corneal ulcers annually in our country. So this is the magnitude of the thing which we are discussing. And what we do is that the progressive corneal ulcers, which are not responding to medications, their definitive treatment is in the form of penetrating keratoplasty only. Either the stopgap arrangements are TN patch graft or whatever we do when we don't have the, when we have a paucity of tissues. Now the post-operative outcome of these type of cases have considered variety of factors, among which infection eradication is one of the most important. Second is visual acuity, whether there was a history of an associated trauma in those cases, whether there was any use of traditional medications, or whether there was a scleral involvement when the patient reached you, or whether there was any coexisting disease. So these all factors were responsible, taken into consideration for evaluating the postoperative outcomes in various studies. So keeping all this in mind, we analyzed the clinical outcome of 100 cases. A retrospective analysis was done at AIOCMTC1 at Patna, and TPK for non-healing keratitis with or without perforation with a minimum 1 year of follow-up was done. We excluded patients with vitreous exudates on arrival to us. So records of patients between October 2014 to 17 were thoroughly analyzed, and primary treatment of these patients were in accordance with the severity of the presentation, and primary microbial evaluation was performed at the time of presentation and was repeated after a week in cases of non-responding ulcers. Initial antimicrobial treatment was modified as per the culture sensitivity report and the clinical response to the treatment as is done by any clinician. Posterior segment evaluation was done with the ultrasound B scan to rule out any involvement of the vitreous. Now, keratoplasty was performed after the initial management failed in non-responding progressive ulcers, ulcers with desmotocele, and patients presenting with a perforated corneal ulcers. Now the donor cornea utilized in the surgery was all of them we utilized the therapeutic grade tissues, and the average size of the graft used was around 9 millimeters. In our study, what we found is that primary lens removal was done in cases where anterior capsule of the lens was already compromised at the time of surgery. And the donor button was larger than graft size by 0.5 millimeters. It was a standard protocol and was secured with 10-0 monofilament nylon sutures. Post-op medication which was used was antimicrobials and the supportive treatment as cycloplegics, intraocular lowering agents as and when required, along with the lubricating drops. We considered post-operative glaucoma, post-TPK glaucoma in our cases where the IOP was greater than 21 millimeters of mercury on NCT, or digitally raised IOP where the measurement was absolutely not possible. Now what we did is the success of surgery was measured in terms of infection eradication and maintenance of the globe integrity. I will emphasize why we put this way. Other factors considered were the need of repeat surgery, an IOP control, and the presence of the graft clarity. Now these patients were followed up for 1 year. So on presentation, all the ulcers were graded as per this classification proposed. 15 cases presented with corneal perforation larger than 3 millimeter in size. 22 cases had descemetocele at the time of presentation, and scleral involvement was found in 6 of the cases. The nature of the microbial pathogen could be ascertained only in 60 patients, and the rest 40, the microbial report was inconclusive. So coming to the distribution of the organisms, 65% were of fungal origin, and rest 20% were bacterial, and 15 had mixed infections. And most common fungus was Aspergillus found in our cases. Lensectomy during TPK. 10 cases were found to have lens involvement with the primary infection, and removal of lens matter was done, and sparing the posterior capsule in 10 of the cases. And 7 cases had inadvertent removal of the lens bag complex, and there we did a thorough anterior vitrectomy, cleaned, and then put up the graft. Now, talking of the graft clarity allowing the view of the anterior chamber could only be maintained in 26 cases. 15 of which 15 were of bacterial keratitis preoperatively seen on microbiology. 5 had fungal pathology, and in the rest 6 cases were those cases where the microbial findings were inconclusive. Now again, coming to the distribution of organisms in cases of graft infection. Now repeat graft infection was noticed in 23 cases. In this also, fungal was the most common, 39%, accounting 39%, and Aspergillus was found to be the commonest. And thereafter, bacterial, and there were few patients, 12 of them, where we didn't have a conclusive microbiology report earlier on presentation. Now, talking about the graft infection, the earliest onset of infiltrate was seen on day 2 of the surgery, where we found graft infections. Now, none of the cases, I'll just take 2 minutes more. Okay, oh yeah. Okay, I'll just take a couple of. So, what we were talking is graft clarity, where it was graft infection. It was seen earliest on second day of the surgery, and none of the cases got any kind of a graft infection after 3 weeks of surgery. And they were treated depending upon the microorganisms isolated. Now, in cases where primary pathogen was not known, in cases of inconclusive microbiology reports, topical and systemic antibiotics were the main arm of the treatment. Now, by all these things, anatomical restoration could be maintained in 96% of the cases. 4 cases required evisceration despite all measures done. Now, coming to the stats is that the repeat TPK was 7 out of 23. Now, in glaucoma, 10 out of the 47 cases of secondary glaucoma were seen in our total 100 patients. And in the 4 eviscerated patients, 3 of them had prior scleral involvement preoperatively. So, in this what we found is that the graft infection rate in our study was around 23%. Success rate, as we considered the success rate as a restoration of the globe. So, in bacterial cases, we found maximum, followed by the fungal one. Globe integrity was salvaged in 96% of cases, and graft clarity was 26% at 1 year. And of those, bacterial were 57%, which was slightly lower than which was shown in other studies. Those patients having fungal pathology were around 19%, which was also slightly lower than other studies. Maybe this may be because of a shorter volume, plus more dirty cases do report to our centers. And a repeat penetrating keratoplasty was required in 30% of graft infection cases, which is slightly higher than other studies. So the volume of the number of cases which we have seen is limited, and the follow-up period was shorter. But despite that, the graft infection rate was quite higher than the other studies. And in glaucoma, surgery was required in around 21% of post-TPK glaucomas found in these patients. And evisceration required was around 4%. So what I want to conclude is that post-operative successful outcome can be considered in terms of salvaging the tissue by infection eradication and maintaining the globe integrity. No matter at that point of time whether the visual outcome, whatever it is coming, at least if you could have salvaged it, because different cases behave differently. In many dirty cases where you feel that this eye is going to be absolutely gone, those cases also do turn up later on, and then you find, okay, fine, we can register him for an optical, and then things behave in a better way. So sight restoration procedures can be taken up later. One should think of infection eradication and maintaining the globe integrity if the tissue is available. This has been accepted in the Kerala Journal of Ophthalmology, waiting for publication. So this was all what we could find out. Because TPKs are, every clinician is encountering non-resolving corneal ulcers. Every clinician doesn't have the access of the microbiological evaluation and a tailor-made approach how to move ahead depending upon the microbiology report. So I would say majority of the centers are receiving dirty cases. All kinds of multiple medications have been tried and done, and then you have to move ahead for a salvaging procedure or infection eradicating procedure. So we should think in these terms that yes, you should try to save maximum. Dr. Shah is here. He has been doing
Dr. NILESH, thank you for a wonderful talk. Actually, this problem is there in our part of India because the Western literature says that you have a very good response to vancomycin. In our experience, and the recent report from the LVPI also says that 36% is gram-negative, which is not responding to any other medicine except cholesterol or piperacillin. So this is a new drug which you must have in your armamentarium to use in all the patients. Do not go for ceftriaxone and vancomycin alone.
Yeah.
Number one. Number two, in my center we have at least 6 to 7 corneal ulcer every day. And what is the biggest thing we have learned in last 5 years is scraping. Scraping is the most important thing, and you do it with betadine. 5% eye drop is available now. So you must scrape every 7th day so that the load of the bacteria goes down. And I will share my experience. Those mixed infection, they 99% I would say in my practice they have improved now with using betadine as the first line of scraping drug. And number 2, we use amniotic membrane in most of the patients who have got 7, 8, 9 drugs coming on the cornea. So you stop all these medication and use betadine and put AMG in your patient to save the non-healing corneal ulcer to stop melting. And if you do not have that, yesterday only morning we did one case, we had kept for therapeutic keratoplasty, but we changed it to anterior chamber wash and amniotic membrane transplant, because when I opened the anterior chamber, it was full of pus. And the pressure was very high. So in all the patients who are not doing well, you have a limbus to limbus pus and you are not able to see the inside, and the B scan is normal. In all those patients you must do anterior chamber wash. And then you do a amniotic membrane grafting, because if you put a therapeutic graft, it will melt or it will not work as well. So
sorry to interrupt, sir. We have short of time.
Okay, thank you.
We have many questions to you, Dr. NILESH. Probably will take it later.
Sure.
We have just 5 minutes left. May I invite Dr. Shatrajit?
Thank you everyone.
Thank you very much, Dr.